I'm Shailendra Achawal. I'm one of the consultant neurosurgeons based at Achawal Infirmary, and I'm speaking on behalf of all my team. It's not just me, because anywhere you deal with cancer, it's always a teamwork. And I have been chairing the Brain and CNS Cancer Clinical Expert Group. This is the network that have been managed recently, and it's a shame really that we have lost those networks, because there have been some achievements. For example, appointment of the neuropsychologist here in our team was one of the achievements that we did through the network. I also chair the Brain and CNS MDT. Ours is the single treatment center for the whole patch as far as the active neurosurgical treatment is concerned, and also active oncological treatment is concerned. One important peculiarity of this patch is the patients from York do come to Hull for the treatment, even if the cancer network is actually towards Leeds. And this is as a result of sort of effective relationship and partnership that the neurosurgery department has developed with York over so many years, and we are proud to carry it forward. And this is a very peculiar thing as compared to the other cancer sites. We did design our guidelines, and they are available on the website which I'm looking here. Now MDT, I must, I will never stop speaking good things about my MDT team, because everybody is so well tuned and passionate about the work that goes through the team. And if I'm allowed to say, I've got a team of leaders. Everybody, practically my MDT coordinator can lead the whole MDT coordinator team in the trust. So is Louise, she can lead all the CNSs in the trust. So I'm really fortunate, so I don't have to do much. It just goes on, and it does go well. So it's a very homogeneous team, everybody's voice is heard, and important thing is also you have to be good on paper, and we have been compliant with the peer review. Brain and CNS was one of the last ones that came in, and right from the beginning we have been more than 70% compliant, in spite of our center being a small volume center, not having all those luxury of having lots of people around, but still we have been compliant and active as well. We have conducted study days and all. Now, really speaking, the part of the pathway that neurosurgery deals with is actually very small. Having listened to lots of talks, there's much more than sort of active neurosurgery. So I will just speak to what are the more details within my part. Advanced imaging like MRI spectroscopy perfusion study is available, and we even carry a special MRI research study. Then surgical aspects of brain tumors, we do have neuronavigation facility. We have started doing awake craniotomies. Now this is a specific thing that we do when the tumors are close to an eloquent part of the brain. We keep the patient awake, and when the patient is awake, we remove the tumor from behind. So that's a technique that we developed, and we have been doing it now almost for 4 years or so, and it's going on well. The other thing that we could add is a 5-ALA, which the training and the microscope we have, but the funding for 5-ALA, it's a specific dye which lights up when a specific microscope filter is used, and you can actually detect the tumor. So the part of the tumor which you may have left behind thinking that it's a normal tumor, that could also be removed if you use this dye. And it's a funding problem, and that's nationwide, and therefore even if we have a training and facility, we are not using that as yet. Neuropathology turnaround time has been excellent, and we never struggle with that. The post-MDT clinic, it's important to communicate the decisions made in the MDT to the patient as quickly as possible, and that we do within 4 or 5 working days time. This is a new development that we did, and we set up separate clinics for that. The MDT coordinator has power to just put the clinics into the oncology clinic straight away. So as soon as the histology is available, the same week the oncology appointment is made. I have worked in other units as well, and I know that this is the best practice, because people or the patients have to wait for their oncology appointment for quite some weeks in some centers. So oncology treatment also happens within time limit. We do a combined follow-up clinic, and we do talk about high-grade tumors, but there is also a category called low-grade gliomas, which is a separate entity. Those patients have a longer survival, so their problems are completely different and separate than what a high-grade glioma patients deal with. And we do have a separate high-grade glioma clinic for them. Achievements, there have been no breaches in the national target. Now when the national targets were set, it's a 3162, 62 for the definitive treatment. When you know glioblastoma by itself has 12 to 13 months of survival, 2 months is too long a time. I think that's the wrong target. 62 should not be 62 for brain tumors, it should be 31 actually. So we do aim at 31 and we do really treat them very quickly. We have shown by audits that the survival of GBM has improved. We have been logging them from 2008 till 2012. Now the weaknesses, as were mentioned before as well, that the referrals to the MDT could be more quick. We do get referrals on a Friday afternoon after the MDT is done that, okay, we have got a patient who had a scan done on Monday, and the report has been available on Thursday. We realize that he has got a brain tumor. Can you take him up? So we just feel, oh, why this was not sent to us, and we could have discussed straight away in MDT and made the decision. CNSs are overworked, that's one of the weaknesses. Louise will speak about it later on. And the post-surgery rehabilitation, we have a Macmillan therapy team at the moment, but I understand it's sort of a limited time, and they are making a difference, so that is something that should be continued. Concerns early referral from GPs, we have heard before, MRI should be accessible to all the GPs. Critical care capacity has been one of the issues recently, and we had to postpone some of the craniotomies for lack of high dependence unit bed. As I said, Macmillan therapy team is for limited time, and we may lose benefit if the therapy team is discontinued. Prolonged hospital stay for lack of community facilities is another concern, and I think that is one of the aims that we should work towards. Follow-up scans nearer the base hospital, like all the brain tumors need follow-up scans, and if there is a robust mechanism set up so that they can have it in the peripheral hospital and they just need to be electronically linked to us, that would be very good. Thank you.